looks like we do have a question for Dr. Grievous. So, Petros, do you want to read this question? I know you responded, but for the benefit of other viewers, if you want to summarize the question and your response.
Sure. First of all, congratulations to Dr. Simon's great talk. I learned a lot about GYN oncology. It's good for my boards that might come in the near future. and also to see the data across tumor types, actually very useful. I want to answer the question by Dr. Karki. The question is very practical and important in patients who have borderline creatinine clearance. And you want to give the neoadjuvant chemotherapy. Do you do that? And do you use maybe split dose cisplatin before radical cystectomy? And the short answer is yes. My cutoff for using cisplatin in the neoadjuvant or adjuvant or metastatic setting is usually 50 cc per minute or higher. And in this category of patients between 50 and 60 creatinine clearance, I may split the cisplatin dose. There is limited retrospective data on that. We actually published on that before when I was at the Cleveland Clinic with one of our fellows. So a very small number of patients, so limited sample size that split dose cisplatin did not compromise pathological complete response rates. Some other data were concerned that they might actually reduce compared to the standard dose. But I try to give cisplatin if I can, if I think it's safe. I try to use it, in these borderline cases. I give plenty of hydration before and after cisplatin. I may bring the patient back, later in the week, make sure the creatinine is still okay to give extra fluids, but I try to get them through in otherwise cisplatin fit patients. So I have used it in this setting in the attempt to try to eradicate macrometastasis and also to downstage the tumor. And as I mentioned in my talk, I do not use carboplatin as neoadjuvant or adjuvant in resectable bladder cancer. I may use carbogem in metastatic disease in those patients who are not fit for cisplatin. I also type answer in the chat room for people to read.
Great, thank you, Petros. So Elise, I have a question for you. Amongst all the different gynecologic cancers, what's your comment on maybe what we'll know about the inherent immunogenicity of these different types, maybe relationship to smoking status, tumor mutational burden, and the PD-L1 expression, whatever surrogate you want to use, if you can comment on that. And then once Elise is done, Petros, if you could do the same for bladder cancer as well, please.
Yeah, sure. No, that's a great question. So obviously these IO therapies we've heard a lot about them today, and they were notably absent from my discussion of ovarian cancer. And it turns out that ovarian cancer is not a particularly immunogenic tumor, unfortunately. And like Petros presented the Javelin data for bladder, but for Javelin ovary, it was just an entirely negative study, unfortunately. There are some ongoing trials looking at IO therapy, particularly in combination with PARP. One of those is the first trial, which we have open at the U and are enrolling pretty well, which is niraparib plus, I can't remember which IO agent it is, to be honest, but sorry. We'll see how that pans out, but unfortunately, we just haven't seen much of that immunogenicity for ovarian cancer. In contrast to that, of course, is cervical cancer, a virally mediated malignancy. 99% of all cervical cancers are related to HPV infection. These do seem to be highly immunogenic. And I don't actually think we've necessarily found the right biomarker for that. Most of them are microsatellite stable. They may have a favorable composite PD-L1 score, but to be honest, we've all seen responses to immuno-oncology agents, even in patients with low CPS scores. And so I don't know that we've actually found the right biomarker, and I wouldn't necessarily let that stop me from using an agent in that setting. And then in endometrial cancer, we do use MMR or MSI as a highly predictive biomarker. Again, there's I think a lot more heterogeneity in terms of endometrial cancers, how immunogenic they are and the utility of immunotherapy in that setting. And then the only other thing I would say is we have basically no data in our rarer cancers, even some of our HPV-mediated cancers like vulvar cancers that we would expect to probably behave similarly to cervix cancer, but we just simply have no data to guide us in that setting.
Great, thank you. So Petros, my question was more related to the immunogenicity of bladder cancer. A proportion of patients in the metastatic setting respond to PD-1 inhibition. And the question is, is there, I know you talked about PD-L1 expression, but bladder cancer is more of a smoking associated cancer. So I would imagine that it generally has a high tumor mutational burden. And the question is, beyond the clinical parameters, are there other things that could help you select patients in the metastatic setting and also, subsequently in the adjuvant setting?
That's a great question, Stelender. Can you see my screen?
Yes.
Okay, great. So I tried to pull together a couple of slides that I had available for a talk I gave this morning in Colombia, and I was able to come here without jet lag and no airport time. So the short answer is that we do not have a lot of success with validated clinically useful biomarkers in urothelial cancer. So similar to what Elise mentioned, we're struggling with the validation step. We're doing great in terms of discovery, but we have trouble with validation. The only two biomarkers we use in clinical practice in metastatic urothelial cancer, not in early stage, just metastatic disease, is PD-L1 expression. And this can be useful when you try to decide between Carbogem and Pembro or Atezo in cisplatin not fit patients in the frontline setting. If you are PD-L1 low, you give Carbogem. If you're PD-L1 high, you have still both options, Carbogem or Pembro or Atezo, 3 options. Those who are not fit for any platinum, they can get Pembro or Atezo without PD-L1 expression. But PD-L1 expression is okay, but far away from being great biomarker. I will show you some data here in this slide. So the first slide, I'm showing you a study we're doing with community practices. And I don't know if any of the investigators are on this call, but these are community sites in the US. And we try to do outside the context of clinical trials to see what treatment these patients get, chemo or IO, and get tissue and do genomic sequencing and circulating tumor DNA as a blood-based biomarker. And we try to pretty much interrogate the biology of disease and potential immunogenicity and try to make correlations in the real world, community oncology practice setting with outcomes, response to treatment, chemo, IO, and PFS-OS. That's one thing we're doing. The other thing is, I try to go to the biomarker slide here. If I have this is data from 2 weeks ago. We saw this data from the Javelin Bladder 100 trial, looking at biomarkers and immunogenicity. And I will just show you a few examples. We looked at TMB high and low and PD-L1 high and low. There seems to be higher degree, magnitude of benefit with TMB high tumors or PD-L1 high tumors. However, neither TMB or PD-L1 have enough evidence to help us select patients in clinic after the use of chemotherapy. Either switch maintenance or platinum refractory disease, we do not have good biomarkers to select for immunotherapy. In this particular study, we looked at beyond PD-L1 and TMB on a plethora of other immunogenicity biomarkers. We'll look at Fc gamma receptor polymorphisms, variants, immune cell types, innate immunity and adaptive immunity types, Tregs, MDSCs, and also adenine repair gene mutations, gene expression signatures, basal versus luminal, so on and so forth, other signatures looking at angiogenesis. Great data. I am very excited about this data. We're going to publish them soon. They're moving the science forward, but no real practical implication to select patients after chemo for checkpoint inhibition. And similarly, in the neoadjuvant or adjuvant setting, still we have not found any clinically useful biomarker. Just for context, they're completely unrelated to IO. We use FGF receptor 2 and FGF receptor 3 activated mutation or fusion to select patients for an FGF receptor inhibitor erdafitinib in platinum refractory disease. But again, this is a lot of discussion about the role of these mutations in response to IO. There's a lot of debate there, but we're still working hard on clinically useful biomarkers. Long answer, but good question.
Thank you, Petros.